or cyclophosphamide for remission induction. Retoximab has been used in the most recent years more commonly than cyclophosphamide. As you all know, cyclophosphamide is associated with cytopenias and fertility concerns. For that, retoximab has been used, and in at least two major studies published in 2010 in the New England Journal of Medicine, retoximab has been found to be as effective as cyclophosphamide. To use retoximab or cyclophosphamide, evidence is variable depending on the setting. But there is strong evidence to use retoximab in relapsing or severe disease, and less evidence for more fulminant disease with a high creatinine or patient needing ventilation support. So to compare the two doses of retoximab, the 375 milligram per meter square area weekly for 4 weeks, and the 1 gram IV on day 1 and 15, the rheumatoid arthritis protocol, a recent study from last year showed no differences between both doses. So what about plasma exchange and ANCA-associated vasculitis? There has been a lot of conflicting evidence in the last couple of years. I'm going to go over a few of the most important studies. So the MEPICS trial included 137 patients with newly diagnosed GPA or MPA. They were randomized to receive plasma exchange. All patients received cyclophosphamide as an induction treatment, and the results has shown that plasma exchange was associated with higher rate of hemodialysis independence in 3 months. Also, it decreased end-stage renal disease at 12 months compared to methylprednisone alone. However, this did not translate in survival difference. What about the PEXIVAS study? So the PEXIVAS study is the largest study that included 704 patients. 98% of patients had renal involvement, and 27% of patients had diffuse alveolar hemorrhage. Patients received standard therapy with cyclophosphamide or retoximab, and they were randomized to receive plasma exchange or no plasma exchange. Those patients were randomized again to either receive the standard dose glucocorticoid regimen or a reduced dose glucocorticoid regimen, which was 60% less than standard dose. Patients who received plasma exchange received 7 plasma exchanges over 14 days with a median follow-up of 2.9 years. So the primary composite end point for this study was death or end-stage renal disease. This showed no difference between the plasma exchange and no plasma exchange group. With regards to the secondary outcome, again, there was no significant difference. So the conclusion from the PEXIVAS study that plasma exchange did not result in a lower incidence of death or end-stage renal disease than no plasma exchange group. And the limitations of the study that there was only a small number of patients with diffuse alveolar hemorrhage, only 27%, and 8% of them were severe. And also, if you noted from the previous slide that the confidence interval was wide and included 1, so with that, we may not rule out an effect, a treatment effect. So with regards to the meta-analysis, this was recently published in February of 2021. This was initially presented in the ACR. This meta-analysis included the MEPICS study, the PEXIVAS study, and a lot of other observational studies. And again, it showed no significant difference in death. However, it did show decreased risk of end-stage renal disease with PLEX, and for that they've recommended that plasma exchange can be considered in patients at higher risk of end-stage renal disease, i.e. a creatinine of greater than 300. So are we going to use plasma exchange or not in patients with ANCA-associated vasculitis? So the results from most recent trial does not support the routine use of plasma exchange. But it can be considered in cases with severe diffuse alveolar hemorrhage or patients with high risk for end-stage renal disease, but its use must be balanced with its risk, and the most important risk that they found in the meta-analysis was increased risk of infection. Plasma exchange should still be used in patients with dual positive ANCA antibodies and anti-GBM antibodies. So the PEXIVAS study also looked at the effect of using a lower glucocorticoid dosing. So all patients received methylprednisone pulse followed by prednisone orally 1 milligram per kilogram. In the reduced dose, the oral prednisone was reduced rapidly in the second week to reach 5 milligram per day by month 4, compared to 5 milligram per day reached by month 6 in the standard dose glucocorticoids. And they found again that the reduced dose glucocorticoid was not inferior to standard dose glucocorticoids in terms of death or end-stage renal disease difference. Again, with the secondary outcome, they've noted that serious infections in the first year was 27% in the reduced dose compared to 33% in the standard dose. So the conclusion from this study that reduced exposure to oral glucocorticoids was not inferior to standard dose regimen with respect to risk of death or end-stage renal disease. So what about Avacuban? So Avacuban is a highly selective human complement 5A receptor antagonist. They found that C5a and C5a receptor play a role in ANCA-associated vasculitis by driving neutrophil activation. So in ANCA vasculitis animal models, they found that Avacuban stopped the development of vasculitis. So the CLEAR study from 2017 is a phase 2 trial that included 67 patients. They used Avacuban along with different regimens of prednisone, 0 milligrams and 20 milligrams and 60 milligrams. And they found that there was no difference in clinical response between the 3 prednisone groups. So the advocate came to evaluate the efficacy again of Avacuban to induce sustained remission in ANCA vasculitis with using no prednisone at all. They used retoximab or cyclophosphamide followed by azathioprine. And they included 320 patients randomized to receive Avacuban versus prednisone along with standard of care. The primary endpoint was remission at 6 months and sustained remission at 12 months. And the results, they found that Avacuban was not inferior to prednisone for inducing remission at week 26 and sustained remission at week 52. And the safety profile of Avacuban was favorable. So moving on to the maintenance of remission phase. So we should treat patients with ANCA vasculitis for at least 2 years. However, cases of GPA has been relapsing after 2 years, and recent trials have been proposing completing treatment or continuing treatment for another 18 months in probably a certain subset of patients. And we're going to talk about that in the next few slides. So for maintenance of remission, we have retoximab, azathioprine, and methotrexate. Retoximab has been shown to be superior to azathioprine in multiple trials, so it should be considered as first line unless it's not available or patient developed any side effects to retoximab. Then we would use azathioprine or methotrexate. If the above are contraindicated or failed to sustain remission or response, then we would use Cellcept or leflunomide. So there have been trials looking at the role of low-dose glucocorticoid in maintenance of remission. It's not yet established and it's not definitely demonstrated yet, but there are at least 2 ongoing trials looking at whether to use 5 milligrams prednisone versus 0 milligrams in sustaining or maintaining remission. But the results of those trials are not out yet. So when looking at the trials comparing retoximab versus azathioprine, we have the main Ritson trial, which is a randomized prospective trial showing that retoximab was superior to azathioprine in sustaining remission at 28 months. I have to highlight that cyclophosphamide was used for induction in this study. They followed patients up to 60 months, and they found that retoximab remained significantly superior to azathioprine to maintain remission at 60 months. However, when the treatment was stopped, the relapses continued to accumulate. What about the Retazarim trial? Again, comparing retoximab with azathioprine, but here the patients had relapsing ANCA-vasculitis, and retoximab was used for induction, not cyclophosphamide. They used a higher dose of retoximab, 1,000 milligram every 4 months, and patients were followed for 36 months. So they enrolled 170 patients with relapsing ANCA-vasculitis. They gave them the every 4 months retoximab dosing versus azathioprine. And they found that, again, retoximab was superior to azathioprine in preventing disease relapse in patients with relapsing disease. They extended follow-up to 48 months, and again, retoximab was superior to azathioprine. However, when the treatment was stopped, the relapse was noted in both groups, but was higher in the azathioprine group. There were no serious infections, or let me say they were similar. Hypogammaglobulinemia was more common in the retoximab group. So how long should we continue maintenance with our treatments? So the main Ritson trial, a randomized double-blinded placebo-controlled trial, took patients who were in remission from the main Ritson 2 trial who had already received treatment for 18 months and randomized them to receive an additional 18 months of retoximab every 6 months versus placebo. And they've noted that the relapse-free survival and the major relapse-free survival was higher in the additional or the continued retoximab group for another 18 months. Thus, prolonging retoximab is effective in sustaining remission without significant increase in adverse event. So we probably should consider prolonging retoximab for patients with high risk of relapse, so patients with PR3 ANCA positive or patients who had a prior relapse. So what about Bilimumab and other treatments like abatacept? So the PREVAST trial was a negative trial using Bilimumab in ANCA vasculitis, but we can learn from this trial that patients who used Bilimumab and were on retoximab or had retoximab subgroup in this trial had no remission. And that tells us that, and we know that retoximab increases BLEST levels, so blocking this stimulator with Bilimumab may improve disease. So that's why another study is conducted, but results are not available yet, using retoximab with Bilimumab versus retoximab alone to see if that would work. Abatacept, there is an ongoing trial using abatacept for the treatment of relapsing non-severe GPA to study the efficacy of the drug to achieve glucocorticoid-free remission. So the take-home messages from my talk, with regards to glucocorticoids, the use of reduced dose glucocorticoid was not inferior to standard dose when considering death or end-stage kidney disease. Reduced dose was associated with decreased risk of infection. Consider rapid reduction of glucocorticoid dose for induction of remission in severe ANCA vasculitis. Some literature suggests to go down to 7.5 to 12.5 at the 3 months mark. Future treatment regimen may use significantly less or potentially no glucocorticoids. What about Avacuban? If confirmed safe and cost-effective, it may be an exciting alternative to glucocorticoid in ANCA-associated vasculitis, but more information is needed to study the effectiveness in all disease manifestations. With regards to plasma exchange, we should not be using plasma exchange routinely for all cases of ANCA vasculitis and should be reserved for severe cases of pulmonary hemorrhage or patients with high risk of end-stage renal disease or patients who have anti-GBM antibodies as well. With regards to the remission maintenance, retoximab has been shown to be superior than azathioprine for remission maintenance with lower risk of relapse. The higher dose of retoximab, 1,000 milligrams every 4 months, did not appear to have more advantage over the known 500 milligram dose every 6 months. relapse do occur after the treatment is stopped, and prolonging retoximab treatment for 36 months is effective in sustaining remission without significant increase in adverse events. So we would consider prolonging retoximab in patients at high risk, such as positive PR3 or prior relapse. The duration of retoximab is yet to be determined, and a lot of studies are ongoing with that regards to see if there are any markers that they can measure, like the retoximab, like the trough level or the antibody levels, to tell us when to give another retoximab dose or to stop. So the conclusion, these diseases are heterogeneous in presentation. Further research and individualization of treatment according to the disease subtype, genetic factors, risk of relapse will be necessary to truly offer a state-of-art therapy. Thank you very much.